The number one reason that we have not been able to get a handle on this is because we have such prejudice, which is not held across the world. We have such prejudice against buprenorphine and methadone, what's called substitution therapy, that only 8 to 10% of treatment programs offer it. Right? So, in the AIDS epidemic, when they came out with highly active antiretroviral medications, there were no doctors, to your point, there were no doctors that said, but I don't believe in using them. I don't believe in using highly active antiretrovirals. I just want to put my HIV patients on a good diet. Right? Well, there's no evidence, there's no scientific medical evidence that putting someone with HIV on a good diet would help them manage their illness, and so it doesn't happen. But in the addiction field is so divided in part because the scientific medical community ignored the field for so long. And so we've started developing an industry based on mutual support and the intuitions that people have in helping one another get well. And I have nothing against that community that developed those traditions and principles. But now that we're dealing with this unparalleled mortality crisis, and now that we do have medications that decrease mortality risk, we have to make a shift. We have to make a shift. It's not a question. I mean, if our number one priority is preserving lives, we absolutely have to make medications the first line of treatment for people with opioid use disorder. You know why?
Keep them alive long enough to treat them.
Because there's no other intervention. I've taught the course on addiction at Washington University School of Social Work. I'm 10 times. I've taught 10 semesters, not even in a row, so over maybe about 7 years. And I start every class by saying to the class, if you can find me one clinical trial that shows that psychosocial treatment for opioid use disorder, a well-designed trial that shows any psychosocial intervention, cognitive behavioral therapy, motivational interviewing, 12-step support, anything, decreases the mortality risk associated with opioid use disorder, you don't have to do any other work in the class. You get an automatic A. There is no research, and people have tried. There are no studies that show we can reduce opioid-related mortality risk with psychosocial treatment. We knew this. We've known this for decades. Back before methadone, we had what was called the narcotics hospitals. I don't know if you remember that. The narcotics hospitals in Lexington, Kentucky, and Fort Worth, Texas. And the reason that the federal government built these hospitals was because of a prior opioid epidemic. And the opioid epidemic at that time was also very much driven by doctors who were prescribing opioids and didn't know what they were, how powerful they were. And the federal government outlawed the prescription of opioids by doctors to people who had opioid use disorder and created an illicit market for opioids, and then we wanted to treat people who had opioid addiction. So they created these places where you could go, and they were the places where all the best researchers in the world wanted to go and study addiction, because we knew very little about the brain during this time. I'm talking from 1935, and they finally closed in 1975. These federally funded narcotics hospitals. Well, you could go there for 9 months, and it was good, clean living. You would work on a farm, you would get therapy, nothing like the 21 days, or you fight for 15 days in residential right now. People could stay for 9 months. This was long-term, and the idea was that you could dehabituate an individual that was addicted to opioids through a major change in lifestyle and through a lot of therapy. And then they studied these individuals who had gone to the narcotics hospitals when they returned to their natural environment. And well over 90% of people relapsed to heroin use. Most of these people were addicted to heroin, right? It doesn't work. It doesn't work. Now, I have a couple friends who work a 12-step program and have never, where they've used medication, but they don't use medication. I have anecdotal stories where people's illnesses remit without medication, but we can't prescribe treatment based on anecdotal evidence. If one person or two people, if 1% of people can do it without medication, that doesn't mean that the other 99 can. We have to look, we truly have to just look at the science about what works.